This short video is an outline of our local safety standard for invasive procedures developed at the Chelsea and Westminster Hospital in collaboration with our colleagues at the Royal Brompton Hospital for safe tracheostomy placement in adult COVID patients. This slide shows the printable locksip that can be used for procedure planning and documentation. The idea is that it follows multiple stages of the WHO pre-surgical checklist, but dissociates these into the procedural planning, which should be done outside of the patient environment and not in PPE, and minimises the procedural contact time. From our limited but growing experience with this procedure in these patients, we have developed the locksip to ensure that the team is familiar with the procedure and critical steps, whilst minimising risks to both patient and staff. In ideal circumstances, these procedures will be performed by teams familiar with working both with each other and with the procedure. However, we do identify that given possible patient numbers and unfamiliar working environments, we have tried to produce a document that will allow teams who do not typically work together, may not perform tracheostomy frequently, who have not had previous experience of PPE, to perform this as safely as possible. The resource implications for taking infected patients to theatre may not always be possible, and consequently a bedside procedure has been developed. We are aware that there is controversy with regards to swabs from the upper and lower respiratory trees, and essentially the patients must be assumed to be shedding active virus at the time of the procedure. We're also aware that in these patients, they may poorly tolerate prolonged periods of hypoventilation, and the protocol has been set up to try and minimise this. Following on from this, while an operating theatre with negative pressure ventilation and an antechamber will obviously be the optimal environment, this may not always be practical. Consequently, this protocol is there to advise teams to minimise the risks both to themselves and to patients, given the resources that they may readily have at hand. Mirroring the WHO checklist, step 1 is for team members to introduce themselves, the senior anaesthetist and airway lead, with second anaesthetist if available, anaesthetic assistants, the lead surgeon and surgical assistant, the scrub assistant, and number 7, the positioning assistant or first runner. And this is someone who will be key in the physical moving of the patient to the optimal position for surgery, to obviate the need of the surgical team to be involved with this with their sterile PPE. At this point, it is useful to review any essential imaging. The most recent chest x-ray will give an indication of how far the oral endotracheal tube can be advanced towards the carina at the time of tube exchange, in order to minimise the chance of inadvertent deflation of the cuff by tracheal incision. In some patients, a degree of laryngotracheitis has been described, although it is not clear whether this is viral related or pressure related from large-sized tubes being placed. It is prudent to cross-reference with any notes from the original intubation of the patient to ensure that the senior anaesthetist has a sufficient understanding of the upper airway should emergent reintubation be required. The next step is to identify any patient-specific concerns. It's outside the scope of this presentation to determine the appropriateness of the procedure. It is expected that the ITU team will have identified the appropriate clinical indications for tracheostomy. known coagulopathies, attachment to the hemofiltration device, or very high oxygen requirements may preclude tracheostomy placement. The review of a recent chest x-ray has been covered. Consent should be obtained, ideally with involvement of the relatives by telephone. The team should be updated of any coagulation issues and current medications, together with drug allergies. Although these are not trauma patients, there may be pre-existing conditions such as rheumatoid arthritis that may preclude significant cervical spine extension. These should be noted, together with any other contributions for a difficult airway. Enteral feeding should have been stopped at an appropriate time and the nasogastric tube aspirated. Step 4 is to identify any specific anaesthetic concerns. It is very important that the senior anaesthetist is not only familiar with the procedure, but familiar with the ventilator the patient is attached to. Specifically, they should be able to use this to perform lower frequency, lower pressure, fixed volume mode ventilation as required, and also hold the ventilation in the end expiratory phase, turn off the ventilator and clamp the tube just prior to cuff deflation. A check of the current monitoring and lines should be done, particularly identifying lines for TPN feed, which ideally should be avoided. The medications for anaesthesia drawn up and determined in advance whether these would be infusions or boluses, and antibiotics dependent on trust and unit protocols, plus or minus tranexamic acid, determined in advance. Step 5 addresses surgical concerns. The surgical team should discuss their familiarity with the procedure, particularly the assistant, to ensure that maximum help can be given at the critical time points. Scrub assistants may be unfamiliar with certain instruments, and these are best laid out in advance. Sutures preloaded and syringes filled. The nominated positioning assistant should also understand the ideal patient position, particularly with regards to the neck and shoulder roll and head ring, so that maximum head extension can be obtained to facilitate surgical placement. If necessary, this should be simulated outside of the patient environment before donning PPE, as communication and movement in aerosol protective PPE is difficult. As mentioned earlier, we recommend that the surgical team direct rather than are specifically involved with the physical placement of the patient, not least to retain the sterility of their PPE. As outlined in the last slide, the position of the patient should be discussed in great detail prior to putting on PPE and entering the patient environment. This protocol has been set up to facilitate the delivery of surgical tracheostomy at the bedside. To achieve this, we recommend that the ITU bed is moved as far down the room as possible with maximum space at the head end. We have used a sturdy hand table trolley that we then place at the head end of the bed and attach with cable ties, as well as placing the brakes. The pressure relieving ITU mattress should be inflated to maximum and held at that pressure for the duration of the procedure. The bed should be approximately 10 centimeters above the height of the trolley. The aim of the next steps is to bring the patient up the bed so that their head and shoulders are resting on the trolley, which will afford the surgeon better access to the neck, as well as providing neck extension. Under the command of the senior anaesthetist, the patient is rolled onto a pat slide with a sliding sheet above this. The head ring and shoulder roll are placed in position. The patient is slid up onto the trolley, and the operating surgeon checks the position is satisfactory. These images show a suitable sturdy hand trolley in a portrait orientation at the head of the ITU bed, together with the double cable tie attachments. These aim to prevent separation between the trolley and the bed during patient movement. Depending on the habitus of the patient, it may be necessary to place the table in a landscape orientation. These images identify how the patient will be transferred up onto the extension trolley using the pat slide and sliding sheet to fill the gap between the top of the ITU mattress and the bottom of the trolley. Again, depending on the habitus of the patient, a suitably sized shoulder roll, ideally disposable, should be used and a stable headring placed. We have found it most useful to raise the ITU bed approximately 10 centimeters above the height of the operating table. Clearly, if the procedure is being performed in a dedicated operating theatre, these additional positioning steps are not required. Here, the suitable patient position is simulated with neck extension, a stable head ring, the gap between the ITU mattress and operating trolley bridged with a pat slide. While some form of pressure relief would obviously be ideal, it was felt that this would complicate patient transfer, and for a short procedure, the hard board would be tolerated. The first part of step 6 is to identify the equipment requirements from the surgical perspective to minimize treatment time, patient exposure, and going in and out of the PPE environment. This list should be comprehensive and should act as an aide-memoire to the surgical assistant team to ensure that all of the necessary equipment is available. This can be adapted by the operating surgeon dependent on their personal preferences. It is important at this stage that the tracheostomy tube to be placed has both an inner cannula available and a subglottic suction port to allow endobronchial toileting in the post-procedure stage. The anaesthetic team should also identify appropriate equipment, including the necessary drugs in sufficient dosages to cover the duration of the procedure. This includes sufficient muscle relaxant in patients who may consume large amounts of this to achieve surgical level anesthesia. Appropriate tracheostomy tubes, filters, and reintubation equipment should be prepared. There are more details on this later in the presentation. The next part of step 6 is to do a detailed talk through of the critical steps of the procedure. It's important to remember that there may be varying levels of familiarity with the procedure, particularly with the COVID adaptations, and this is an important step for all team members to understand what will be required of them in a timely and efficient manner during the procedure. Communication is limited in full PPE, so staff should only enter the room with a clear idea of what is required. Following appropriate PPE positioning and anaesthetic drug preparation, the anaesthetic team will perform some video laryngoscopy and oral pharyngeal suction to clear the supraglottic secretions, particularly those that sit just above the cuff of the oral endotracheal tube, to be removed. Subglottic inline suction should also be performed at this stage. The surgical procedure starts as normal with preparation, drape, local anesthesia and marking. With careful standard surgical approach, a wider incision may be favoured, and to minimise potential hemorrhagic complications postoperatively, a bust approach to the anterior jugular vasculature and or thyroid isthmus should be performed. Once the trachea has been prepared without perforation, a short pause in the procedure is recommended to ensure coordination between the anaesthetist and surgical staff. Following this pause, the ventilation strategy of the patient may be changed to a lower frequency, lower pressure ventilation with the ventilator set to a fixed volume. The latter may be useful to stop ventilators cycling higher pressures if they determine that a disconnection has occurred. Without deflating the cuff, the oral endotracheal tube is advanced towards the carina, the predetermined distance. It should now lie below the planned tracheal window. Before perforation of the trachea, a tube exchange timeout is led by the surgical team. This is covered in more detail later. In brief, the tracheal window is then excised, a silk rescue suture is placed, and at this point, in the end expiratory phase, ventilation is stopped and the oral endotracheal tube clamped. It can then be backed out, exchanged for a tracheostomy tube, cuff reinflated, checked, and only at this point will ventilation be recommenced with checking for end-tidal CO2. The rationale for this is to minimize the period of hypoventilation for the patient, but also of paramount importance is to reduce the risk of aerosolization of any viral particles to the staff. The procedure is completed by securing the tracheostomy tube and careful doffing of the PPE. These key sequences will be covered in more detail in the following slides. Once the team has finished the surgical briefing, only at this point should PPE be donned with the buddy system. As for all aerosol generating procedures, this should include an FFP3 mask, visor, hat and long sleeve surgical gown with double gloving. It may be necessary for additional gown and gloves for staff touching the patient prior to sterile field being prepared. If powered air purifying respirators are available, then they will be the equipment of choice. However, we have developed this protocol for when they may not be available. We have identified that during the procedure, the operating team will have a deficiency of the standard protection in the neck area, and to minimize this, additional use of a surgical hood or a folded gown cover can be used to reduce exposure of bare skin to potential virus aerosol. Dependent on the operative environment, a headlight may be required. Non-disposable ones should be covered with a plastic bag such as a swab bag, which is only semi-opaque and freely available. The donning and doffing of this additional PPE has been covered in a separate presentation. We would always recommend a referral to local and national guidance for PPE requirements. Once the team have donned their PPE, the patient environment is entered and the WHO checklist is completed by identifying that this is the correct patient and if there are any new concerns present. If none are identified, then the procedure can commence.
Optimally positioned, you need to pre-oxygenate the patient for a minimum of 5 minutes and place on an SIMV volume control mode. Identify your IV access that you're going to use for bolusing drugs. Please avoid the TPN line if possible. You need to increase your medications, sedative medications, to an anesthesia level of propofol and fentanyl. And then you will need to paralyze your patient with rocuronium if you haven't done so already. Once the patient is fully sedated and paralyzed, you undertake suctioning, so oropharyngeal suctioning, aspiration of the subglottic port, inline suctioning, and also aspiration of the nasogastric tube. You need to exchange the existing tube ties for some tape so to allow easy withdrawal of the tube during the procedure. And you need to have available 2 clamps for clamping the ET tube, also required during the procedure. At this stage, if you're going to give tranexamic acid, then you would give it now. If you're going to give an antibiotic at prophylaxis, then you would give it now. In addition to the patient preparation, you also need to have your reintubation drugs available, rocuronium, fentanyl and propofol. You need to have your emergency drugs available, including diluted adrenaline. You need to have your airway rescue equipment available, which includes a new tube for reintubation, a stylet and your video laryngoscope, plus a supraglottic airway, a face mask, a bougie, and you will use your video laryngoscope during the procedure to allow both direct vision from the surgeons and also video laryngoscopic vision as the tube is withdrawn. In addition to these airway rescue equipment, on the airway trolley outside you will have your e-phoner kit, and you will also have an ambuscope with monitor available. The tracheostomy and the new circuit with inline suction and nebulizer will be given to the scrub team beforehand so that they can prepare to connect to the tracheostomy once it's inserted.
As previously outlined, the patient is positioned and the procedure is commenced until the point that the trachea is prepared but not incised. At this point, the ventilation strategy changes to low frequency, low pressure, fixed volume, and repeat subglottic suctioning is performed. The oral endotracheal tube is advanced. Up until this point, there is no viral load within the surgical field, except any from a hematogenous source. So at this stage of the proceedings, the trachea has been completely exposed but not perforated, and the endotracheal tube still sits in a just subglottic position. The anaesthetist will be asked to push the tube towards the carina, a determined distance from the preoperative chest x-ray. This can be done without cuff deflation to prevent aerosolization. Once the balloon is felt to be in the area of the trachea distal to the intended site of perforation, here marked with a black ring, the low frequency, low pressure ventilation may be maintained, and the surgeon may make a proximal horizontal incision above, in this case, the third cartilage ring to perforate the trachea. We'll stop. The pressure of the lungs should be held by the cuff, and no aerosol should be generated. As long as this is felt clinically to be the case, then completion removal of the ring with careful preservation of the cuff should be continued, again with low frequency, low pressure ventilation. Immediately prior to tracheal incision, a tube exchange timeout is called. The lead surgeon will check with the scrub assistant that the tracheostomy tube selected is unfenestrated with a closed subglottic suction port. The cuff patency is checked and the inflation syringe loaded. Inner tubes and alternate tracheostomy sizes are to hand. There is suction available and on. The 2O silk tracheal ring rescue suture is loaded, and a bowl of suitable liquid is available in the rare occasion of an airway fire. The second part of the tube exchange timeout is addressed to the anaesthetist, confirming that inline suction has been performed through the subglottic port of the oral endotracheal tube and any secretions above the cuff have been cleared. It is confirmed that the oral endotracheal tube cuff has already been advanced distal to the planned tracheal window. The cuff remains inflated with no obvious air leak, that the low frequency, low pressure ventilation is confirmed, and that the anaesthetists are ready to stop ventilating when required. Because many of these patients are sensitive to prolonged periods of hypoventilation, the ventilation is not actually stopped until tube exchange is required and the initial tracheal incision is performed with the ventilation still running. This slide shows the connections of the tracheostomy tube that need to be prepared prior to tube exchange. An appropriately sized unfenestrated tracheostomy tube with a subglottic suction port together with an inner cannula not shown on this slide. The introducer should be at hand, the tube lubricated and the cuff checked. A tube connector with an inline suction already attached, tube extension, nebulizer attachment and appropriate filters should all be prepared. Fully exposed and prepared, a window opened and the rescue suture placed, one tracheal ring below, the procedure may continue to tube exchange. With clear communication to the anaesthetist, the ventilation is switched off at the end expiratory phase, with the intrathoracic pressure only atmospheric. A sturdy clamp is placed on the oral endotracheal tube and the cuff then deflated. This should not result in an aerosol into the operative field. The tube can be withdrawn slowly until, under direct vision through the operative site and through video laryngoscopy in the mouth, it is clearly seen that the tip of the oral endotracheal tube lies above the window, at which point the tracheostomy tube can be placed under direct vision by the lead surgeon into the fenestration. The tube is inserted firmly and positioned into the trachea. With the cuff inflated and ventilation continuing, the 2O silk tracheal ring rescue suture is placed and clipped. Hemostasis is performed and suctioning if required. Extreme care must be taken with the secretions emanating from the lower respiratory tract. The ventilation is paused in the end expiratory phase with the clamping of the oral endotracheal tube. At this point, it should be confirmed that the intratracheal pressure is atmospheric. Consequently, when the cuff is deflated and the tube withdrawn to the level of the cricoid above the tracheal window, there should be no obvious aerosol of viral containing fluid. Suction again should be used only if necessary, the tracheostomy tube placed under direct vision into the trachea, the introducer removed, and an inner cannula immediately inserted. Tube exchange is completed with holding the tube in position while the cuff is inflated and it is confirmed that the pressure is holding. The ventilation circuit is reconnected and ventilation re-established. End titles CO2 confirms successful ventilation with observation of bilateral air entry without surgical emphysema. The tracheal ring rescue suture is loosely tied, taped and labelled. The tracheal tube is secured with 4-quadrant sutures and tapes, and the wound approximately closed at the edges if required. The surgical procedure is now complete. The tube exchange has been achieved, the introducer is removed, but critically, ventilation is not recommenced until the cuff has been inflated, a formal seal confirmed, and the ventilator can then be reattached through the appropriate filters to ensure that a complete seal is present prior to positive pressure ventilation. The aim of the rescue suture, if placed, is to provide a post-operative method of bringing the distal trachea towards the stoma wound in the possible but unlikely event of early decannulation without mature stoma formation. It is important that the suture is tied loosely outside of the body and appropriately labelled to prevent inadvertent removal. Enclosing the ends in a 5mm syringe is a useful method for doing this. The careful doffing of the PPE equipment is probably the most important stage to prevent inadvertent contamination of yourself or colleagues. It should be done according to local protocols using a buddy system. All PPE should be disposed of in appropriate waste bags, and careful decontamination of non-disposable items must be performed. If an antechamber is available, this should be used as appropriate. A further video presentation is available for the doffing method of the additional protection recommended in these procedures. Finally, appropriate documentation using either paper-based or electronic patient record systems should be performed. The most important surgical parts of the procedure noted, together with the type and size of the tracheostomy tube placed. It must be remembered that the ongoing management of these patients may include transfers to other institutions, and appropriate information regarding the tracheostomy placement must be freely available. It is also important to remember that these patients may also be cared for by staff not completely familiar with tracheostomy placement, and appropriate educational resources should be available both with the patient and online to ensure that safe care is continued.